Good morning. I have a couple brief announcements before we get started. The first announcement is that I've been informed this week that we will be no longer using the bubble sheets as of next week for our CME. If you haven't received an email from sort of the CME office, I'll send something out next week in terms of the electronic replacement that we'll be using, and hopefully it will go nice and smoothly. The other brief announcement is that after grand rounds at 9:05, Dr. Andy Goodwin from Hematopathology wanted to come by and just speak for a couple minutes about the new heparin drip monitoring that we'll be doing. So we'll get started. This morning, Dr. Kim Dittis will be announcing our speaker.
So good morning. Can you hear me okay? So I'd like to welcome you to the Laura Mann Integrative Lecture Series and Medicine Grand Rounds today. I want to provide a little insight into our efforts supporting integrative medicine here at UVM. So the UVM Medical Center, College of Nursing and Health Sciences, and College of Medicine, as well as our community partner, the Laura Mann Center, are collaborating to develop an Institute for Health and Healing at University of Vermont. And this will include a three-arm approach, a clinical service arm that will provide therapies that can be used safely and effectively and are evidence-based in conjunction with allopathic medicine, as well as an education component that will provide an interdisciplinary and innovative certificate program for both undergraduates and graduates, and a research arm that will investigate the impact of integrative health approaches on the health and well-being of our patients. So it's my pleasure this morning to introduce the Fall 2015 Laura Mann Integrative Healthcare Visiting Professor, Dr. David Rosenthal. Dr. Rosenthal serves as an integrative oncology consultant at the Leonard Zakim Center for Integrative Therapies at Dana-Farber Cancer Institute and as a senior physician at Brigham and Women's Hospital, Beth Israel Deaconess Hospital, and Dana-Farber Cancer Institute. He's the Henry K. Oliver Professor of Hygiene at Harvard University and Professor of Medicine at Harvard Medical School. He has served as Medical Director of the Zakim Center for Integrative Therapies, as well as President of the Society for Integrative Oncology and Director and Executive Officer of Harvard University Health Services. The Laura Mann Center, the University of Vermont Program in Integrative Health, and the University of Vermont Cancer Center are the generous sponsors of the lecture, and please join us for questions and answers and coffee and breakfast outside of the Davis Auditorium after the lecture. So, Dr. Rosenthal, we're excited to hear what you have to say.
Thank you very much, Kim, and it's a pleasure to be here. Let me warn you first that you don't have to take notes. The slides are all going to be available to you, so I just want you to sit back and relax. But it reminds me of a little fable I once heard when I was teaching at Harvard Medical School. One day I came in and gave this lecture, and the students complained at the end of the lecture that you're talking too fast, I can't take notes fast enough. So the next year I gave them a syllabus, and they were very happy with that, but the next year no one showed up at the lecture. So that's what's happening these days, but it reminds me of a fable about an old man, a little boy, and a donkey. It was a very hot day in Texas, and the old man was pushing this donkey with the little boy down this road when a farmer said to the little boy, "How can you be so cruel to this old man to make him walk and push the donkey down the road?" So the little boy got down, the old man got up on the donkey. They proceeded further until they met somebody who was really concerned about the little boy. And so to make a long fable shorter, the old man pulled the boy up on the donkey, and they proceeded further until they met a farmer who happened to be a member of the Society for Prevention to Cruelty to Animals. So they both got down, they found some wood, they built a litter, and they carried the donkey down this hot pathway. Well, they finally came to a rushing brook, and they figured a way, how are they going to get this donkey on this raft over the brook? So they set the raft down, and suddenly a wave hit the edge of the brook. The donkey rolled off into the water and drowned. And that's the fable. Well, if you know, there are always morals to each fable, and that is, if you try to please everybody all the time, you're going to lose your ass. So without further ado, thank you for inviting me, and this will be the outline of today. I hope I can get through all the slides, but if not, I know we have some other sessions later on with the fellows and with the nurses. But I'd like to talk about definitions and history of integrative oncology, cancer challenges, and by the way, integrative oncology can also apply to integrative health, integrative medicine, so it's not just oncology. But the cancer challenges are what I want to talk about today. I was president of the American Cancer Society back in the late 1990s, and we set some challenge goals, which I'll talk about. Then we'll talk about the integrative therapies that are available, and many of them are already available here at the Cancer Center and at the University of Vermont Medical School. Then a most important aspect, as you just heard Kim say, research is increasingly important. I wouldn't be in this field. I'm a clinical hematology researcher in malignancies of lymphomas, leukemias, and so I very much know that the importance of evidence-based integrative therapies. And finally, we'll talk about the future, where we stand, and how do we combine all of these Eastern medicine practices that are evidence-based with allopathic or Western medicine. So I was put on a committee called the Committee on Quackery back in the 1970s by the American Cancer Society. And yes, there are still quacks around, but we used to go around with cameras to Tijuana, Mexico, to other places with cameras, trying to see what was going on in these various clinics. We realized that no one was being cured of cancer, but some of the people who came out, they died of the disease, but they had a better quality of life. What was it that was going on? We realized there were some things that were really helping people, and that was basically nutritional advice and mind-body medicine. So a lot of things that were going on. So we had to change the name. We changed it to questionable methods of therapy. Then we changed it to unproven therapies. And finally, the government got involved, and they formed a committee called the Complementary and Alternative Methods of Therapy, which the American Cancer Society adopted as well. Now we call it, I was not a very popular fan of complementary and alternative methods of therapy because I don't think those two words should be connected with an and. It's either complementary or alternative. Alternative means in place of. Complementary means it's helping, it's assisting with other therapies. So integrative medicine and health is currently the word that's currently used. The history is that in October 1991, which was the 104th anniversary of the NCI, a public law established an office and an advisory panel to recommend a research program that would investigate promising unconventional methods practices. I'm a good fan of Judah Folkman. Judah Folkman was given a grant back in the 1970s, 1980s, when he was a youngster. And he had this crazy idea that blood vessels were formed by cancer cells, and they helped the cancer cells metastasize. Well, back in the 70s and early 80s, people frowned at this. They couldn't believe it. But yet, this is an unproven method, and he went about the next 30 years showing that angiogenesis is important and that anti-angiogenesis factors are very important in cancer therapy. And we now know that practically, at least at the Dana-Farber Cancer Institute, and I'm sure here, that many of the chemotherapy oncology protocols contain an anti-angiogenesis factor. So that's the kind of unconventional medical practices that need investigation. In June of 1993, the NIH Revitalization Act established the Office of Alternative Medicine. I wasn't a fan of this. The people who were put on this were a lot of people who really hadn't done any research and were promoting, again, there was a question of the difference between quackery and evidence-based medicine. So finally, in October of 1998, they got rid of the Office of Alternative Medicine, created two offices, the National Center for Complementary and Alternative Medicine, which became a center at the NIH, and the Office of Cancer Complementary and Alternative Medicine at the National Cancer Institute. These were established per the Omnibus Consolidated and Emergency Supplemental Appropriations Act. So here we are in those early years, taking us up to 1998. And in 2000, because of all of this energy, there was a complementary therapies task force created at the Dana-Farber Cancer Institute. And this was led to the opening in October of 2000 of the Leonard P. Zakem Center for Integrative Therapies at the Dana-Farber Cancer Institute. Lenny Zakem was a patient with multiple myeloma. As you know, many of you, this is a very painful disease. And he went to the then president of the Dana-Farber Cancer Institute, Dr. David Nathan, a hematologist, and he complained to him. He said, listen, you're giving me the greatest care in the world, autologous transplants, new therapies, but you know, you're not treating me as a whole human being. I have to go to the suburbs to get my acupuncture, another place to go to get my massage, and my son learned how to give me Reiki. Why aren't these things available at the Dana-Farber? So, being a very influential man, he was the head of the Anti-Defamation League of New England, and he convinced the Dana-Farber to at least investigate this, and they formed a complementary therapies task force, and they had this fair, and out of the woodwork all through the Harvard Medical School area, people came out in droves to try to learn about how complementary therapies might be able to help cancer patients. So the Leonard P. Zakem Center was formed, and the ribbon cutting took place in the year 2000. It was created by a lot of philanthropy, a $1 million gift by the friends of Lenny Zakem. And this was essentially a bold initiative by the Dana-Farber Cancer Institute. Because I was a researcher and had done some work with the American Cancer Society on complementary therapies, Dr. Nathan called me into his office and he said, David, I want you to lead this. I know you're going to be helpful in education. I know you'll be helpful in clinical services, but the most important thing here at the Dana-Farber is to do research. And research became a very important component of the integrative therapies at Dana-Farber. So that was the year 2000. The mission statement is dedicated to enhancing the quality of life for cancer patients and families by incorporating complementary medicine into traditional cancer care, providing affordable clinical services for pediatric and adult patients and their families, educating and empowering patients about their use, and conducting peer review research. These were the clinical services that we initially began. We began in one room in the hematology oncology clinic giving acupuncture, and that was a bold step, but it began. We also then started massage, Reiki, and I was doing integrative medicine consults. We had trained nurses, trained dietitians giving nutritional consults. These were all fee-for-service individual. The integrative medicine, integrative nutritional consults were covered by insurance, but all the acupuncture, massage, and Reiki in Massachusetts are not covered by insurance. The group programs, however, with a lot of philanthropy, we were able to cover the complete costs for music therapy, expressive arts, Qigong, Tai Chi, meditation, and yoga. This was our first research project, which was funded by the National Center for Complementary and Alternative Medicine. It was acupuncture for the quality of life of cancer patients, breast cancer patients, ovarian cancer primarily, and we looked at pain interference, pain severity, and pain tolerance with the use of acupuncture given twice a week for 4 weeks, and then once a week for 4 weeks, and then stopped. It's very interesting to see that the pain levels, although they weren't severe, 2.5 mean, did drop down to very low levels, and when the acupuncture stopped, it continued to cause a significant pain relief. So acupuncture, this study has led us to do more pilot studies and also to do some randomized clinical trials, which I'll tell you about in just a moment. So the history goes back. That was 2000, 2001 when we received that grant. Then the Dana-Farber also was very helpful in forming a new society in 2003. Together with Barry Castleth at the Memorial Sloan Kettering Cancer Center and the American Cancer Society, the Dana-Farber established the Society for Integrative Oncology. And this society is now growing, and there'll be a meeting that takes place beginning this weekend in Boston, but it had its first meeting in New York, and its second meeting in Boston, and its third meeting in San Diego. So it's now well along its way to its 12th meeting this coming year. So we've come a long way, but we still have a ways to go. This is just the definitions, as I already told you about: complementary together with, alternative in place of. So we need to make those distinctions, and I'm glad about integrative health being the current term. These were the CAM disciplines: biologically based systems, manipulation body-based, mind-body medicine, alternative medical systems, which are traditional Chinese medicine, and energy therapies. These are ancient terms, and I think they have less quality now, and I think the National Center has not longer adopted them. And I'd like to think more of the categories of integrative therapies as follows: diet, over-the-counter supplements, antioxidants, and herb is one basic category of interest that needs research and is very much on the minds of many cancer patients, and also on the minds of clinicians as we treat cancer patients, and also all patients with medical illnesses who are on multiple medicines, and then we compound that by all of these new over-the-counter substances, herbs, and supplements. Then there's the big category, which is very evidence-based, of mind-body medicine. The work of John Kabat-Zinn, of Herb Benson, really has popularized mind-body medicine, the relaxation response, and the evidence here is very strong as far as the importance in decreasing stress and anxiety. Physical activity and modified exercise programs, no question about it. We now have incredible evidence that exercise is very important for cardiovascular disease, for oncology, as well as other chronic medical conditions. Finally, massage and touch therapies. I know that someone preceded me here at these lectures and talked about massage and its importance in relaxation techniques and in improvement in overall quality of life. And then the fifth category, I have put it aside by itself as acupuncture, because this is traditional Chinese medicine minus the herbs. And we found this to be a very underutilized adjunctive therapy for many patients with chronic illnesses, and especially cancer. And we'll go through some of the evidence for that. So the challenges of the American Cancer Society back when I was president in 1996 to 98 was to reduce cancer mortality by 50% by 2015, reduce the incidence of cancer by 25% by 2015, and to show measurable improvement in the quality of life, physical, psychological, social, and spiritual. Well, we didn't achieve these challenge goals in all cases. We did in some. So the United States has been very effective in reducing some of the cancer mortality, especially in lung cancer, colorectal cancer, and a few other cancers like lymphomas and leukemias. However, we still have a long way to go with melanoma, renal cell cancer, and ovarian cancer. But the incidence of cancer certainly hasn't decreased. The incidence of cancer continues to be level or, in fact, increased. The basic change in cancer mortality, the reduction, has basically been in education by risk reduction, by cessation of smoking, by better nutrition, by physical activity. So, yes, there are a lot of new medicines and new ways of helping, and that certainly has helped create longer survivals. But I think the basic things that have affected the mortality figures are basically the risk reduction by no smoking and good health behaviors. So part of integrative health is promoting good health with nutrition, physical activity, and stress and symptom management. So the quality of life measures, again, goes along with this. So if we have now a decreasing mortality, still an increasing incidence, what does that do to survival? It increases the number of people in the United States who have cancer and are living with the disease, or living, rehabilitating from disease, or having gone into pain and palliative care phases of disease. So there are a lot of people in the cancer survivors who are suffering from the chronic complications of the therapy that produced their remissions or their disease survival. I take care of a lot of people with leukemias. And in the 1970s and 80s, we began to see an increased number of people surviving leukemia and going into remission. But I just saw 3-4 patients this past year who now all have cardiomyopathies and are on the waiting list for heart transplants because of the aggressive therapy that we gave them that saved their lives but caused the cardiomyopathies. So cancer is a chronic disease. With a decrease in cancer mortality, we have more cancer survivors. And so we have to look at their quality of life, and integrative oncology becomes even more significant. So what is integrative oncology? This is a quote by Snyderman and Andrew Weil, Ralph Snyderman, who was at Duke, and Andrew Weil at Arizona. It combines the best of both conventional and evidence-based integrative therapies. It emphasizes patient participation in management and maximizing health. It emphasizes the primacy of the patient-provider relationship and the importance of shared decision-making. It emphasizes the contribution of the therapeutic encounter itself, and it seeks to optimize an individual's innate healing capacity. What about cancer patient use of CAM? And this could go along also with people with chronic illnesses. 83% of patients across a broad spectrum of malignancies use some form of the complementary therapies that we talked about. The highest use is vitamins, herbs, movement and physical therapies, and that's excluding spiritual practices, which would probably raise this even higher to in the 90% range. The expectations were that it would improve the quality of life, alleviate symptoms, cure their disease, boost their immune system. And they did this basically for hopefulness, lack of toxicity, and essentially more control. At the Dana-Farber, who uses the integrative therapies? Patients with pain, fatigue, anxiety, other symptoms, for example, nausea, neuropathy, interest in nutrition counseling for special diets or supplements or other therapies. So pain, fatigue, anxiety, the big three. These are the therapies we talked about already before. The integrative nutrition consults essentially respond to patient inquiries regarding diet, supplements, and herbs, therapies with potential benefits, fish oil for cancer cachexia, excuse me, probiotics for bowel irregularities. I'm going to sit down for a minute. Glutamine for chronic diarrhea, various dietary manipulations for symptom control, and a low-fiber residue diet for patients with various GI problems. The nutrition guidelines are avoid being overweight, obesity, being physically active, avoiding sugar, consuming a phytonutrient-rich diet, limiting red meats and avoid processed foods, and limiting alcohol. Very good self-health behaviors. No-brainers. Integrative medicine consults respond to questions about CAM, safety, and efficacy. I discuss with people the role of integrative therapies alongside conventional therapies. Here's a slide. You've been fooling around with alternative medicine, haven't you? This is from Randy Weiger and David Eisenberg. It's sort of a schema that therapies that may be recommended, evidence supports efficacy and safety. That's no question, it's no brainer. For example, acupuncture, MindBody programs. They're safe and they have been shown to be effective. Therapies that may be accepted are evidence regarding efficacy is inconclusive, but the evidence supports the safety. Therapies that should be discouraged or unacceptable means they're unsafe and they've already been proven to be ineffective, like Laetrile. Laetrile is still out there. People are still using it, but there's no evidence that it's safe and it does contain cyanide. And people have had great toxicity. So we have to be aware of the direct toxic effects, interactions with other medicines, reduced effectiveness of standard therapies, toxicity not related to cancer, impairment in overall quality of life, and most importantly, some people who choose alternative therapies and delay curative types of therapies. So here are some of the direct toxic effects of these agents: Laetrile, cyanide toxicity, shock cartilage, nausea, vomiting, constipation, hepatitis, hydrazine sulfate, hepatorenal failure. There are some, however, some over-the-counter supplements which are very helpful. Vitamin D, omega-3, probiotics. These can also be very helpful. But we have to be very careful about interactions with other medications. For example, ephedra causing cardiovascular effects, garlic, ginkgo, ginseng, causing bleeding, increase against platelet function, hypoglycemia with ginseng, sedative effects and anesthesia with kava. There are now kava, instead of coffee houses, there are kava houses, giving people, quotes, high, but they also have terrific sedative effects. And then St. John's wort, which is a very complicated agent that can significantly interfere with chemotherapy and other medications. For example, the cytochrome P450 system can be either stimulated or inhibited. With St. John's wort, the cytochrome P450 system is increased, which allows drugs to rapidly disappear from the bloodstream well before they become effective. Anti-inflammatory agents, such as nonsteroidals and other types, such as the omega-3s, usually imply antiplatelet effect. And so you have to be very careful about preoperative and causing increased bruising and bleeding. So here's some effectiveness. Here's some agents affected by St. John's wort: cyclosporin, irinotecan. These are all rapidly disappearing from the bloodstream if you're on St. John's wort. So obviously, you can't use both at the same time. And this is one of the complex things that happens when we're doing pilot studies with new investigational agents in chemotherapy and other diseases. We have to make sure that they're not on any of these agents that affect the cytochrome P450 system or isoenzymes. So there's a long list. How do you keep track of all of this? It's very difficult. You have to have some basic databases. And there are a number of databases. If I can show you here. There's one from Memorial Sloan Kettering Cancer Center, mskcc.org/herbs and antioxidants. Will give you a great number of data elements with all of the agents and then the benefits, the lack of benefits, the evidence, the toxic effects, dosage, and safety. The other one that I like to use the best is the Natural Database, the Natural Medicines Comprehensive Database, www.naturaldatabase.com. This is so effective a database that all of our physicians at the Dana-Farber and partners healthcare have a license to use this database. So it's something to think about as you try to look at how do you integrate all these over-the-counter substances that people are coming in with as they start on their chemotherapy or other therapies to make sure that they're not going to interfere with the therapies. So it's a big issue. Suffice it to say, we can talk more about that later. But here are the MindBody therapies. All of these have been well tested. The only one that I think that mindfulness meditation, the relaxation response and biofeedback, guided imagery, self-hypnosis, self-expression in words, music therapy, expressive arts, dance, yoga, tai chi, qigong, all of these can induce in one way or another a relaxation response. And from the work of Dr. Benson in Boston at the Benson Henry Institute at Mass General Hospital, what he essentially has shown that the relaxation response is evidence-based, and the physiological mechanism is that when you do functional MRI studies and induce this relaxation response, by whatever means you try, various parts of the brain will light up on functional MRI studies. And you can actually measure endorphins and neuropeptides in the bloodstream. And you can measure blood pressure going down, you can measure pulse going down. All of these induce the relaxation response. There is one side effect of when Dr. Benson and I go around teaching people how to do the relaxation response. We warn them about the one side effect. And that is, if you stop doing the relaxation response and get up quickly to answer the phone or open the door, you can collapse because your blood pressure will have gone down and your pulse will have gone down. So it's very important to advise people as they get off a table from massage, as they stop their meditation, to gradually let thoughts back into their mind, gradually open their eyes, gradually resume their activity before they stand up. That's the one side effect. But otherwise, these are extremely all evidence-based. You've heard about, from I think back in June, is that right? You had a talk on massage. There are all sorts of different massage types: Swedish massage, aromatherapy massage, reflexology, acupressure, shiatsu, manual lymphatic drainage, Reiki, and deep tissue massage. Some people say that Reiki, which has been called an energy therapy, is hogwash. There's no such thing as not touching the person. These are called healers. But there is now some evidence. We have actually studied Reiki, comparing Reiki to MindBody medicine, and we'll show you a data in just a minute. This was the study. This is a study in brain tumor patients done at Duke. This is for massage. 25 patients, a 45-minute massage session twice a week for 4 weeks. Decreased stress levels, week 2 to 4. 1 week after showed increase, but not the same as baseline. It also increased the quality of life, emotional, social, family, and physical well-being, and specific brain tumor concerns. So it does improve quality of life and decreasing stress levels. Then this is the study that I was talking about, done by Claire Beard from our radiation therapy department at the Dana-Farber. She once walked into the waiting room of the radiation therapy unit where these men were waiting for their radiation therapy for their prostate cancer. They were not a very comfortable bunch. They were all anxious. They were all walking around. And she decided to do a study on them. And so she got 54 men with prostate cancer being treated with radiation therapy, and she assigned them to Reiki versus relaxation therapy or a wait list control to measure trends for effects in anxiety, depression, and quality of life. 2 50-minute sessions of Reiki, 2 60-minute sessions of relaxation therapy for 8 weeks. And the trends showed that both Reiki and the relaxation response showed decreased anxiety and depression and increased quality of life. The most significant was in the relaxation response with cognitive therapy, but Reiki, interestingly, also was better than the weight control group. Acupuncture. Again, as I mentioned before, acupuncture is probably one of the most underutilized adjunctive therapies for many patients with cancer. It specifically has great benefits in nausea and vomiting, one of the first areas that was shown by the NIH to be evidence-based back in the late 1990s. Cancer-related pain, a nice study in the JCO that showed cancer pain being affected, and it's a randomized clinical trial showing that it was just as good, if not better, than many analgesics. Post-chemotherapy fatigue, also a study done at Memorial Sloan Kettering Cancer Center in a randomized clinical trial to show that the basic fatigue index improved in the acupuncture group compared to the control group. Recently, we've seen some evidence about radiation-induced xerostomia, a dry mouth due to radiation therapy that occurs in head and neck cancer patients, as well as lymphoma patients. The studies done at MD Anderson and Memorial Sloan Kettering Cancer and also at the Dana-Farber have shown that xerostomia can be reversed. And now studies are being done to show whether or not we can prevent xerostomia by beginning acupuncture at the very start of radiation therapy. Acupuncture is also very good for insomnia. It also induces the relaxation response and decreases anxiety and stress. And in studies done has shown to be just as good as any of the medicines for the treatment of hot flashes due in prostate cancer and breast cancer patients. So these are evidence, and the question is, what's the right dose? We're still working on what is the right dose of acupuncture. Is it once a week? Is it twice a week? Or is it 3 times a week? And these are the kinds of studies that are currently being done. I don't know if you can see the needles. going in the forehead, in the ear of this youngster, but acupuncture is very well tolerated. And it is very safe. So we've shown efficacy and we've shown safety. We have had no adverse events in over 10 years except for the caution about people getting off the table after the acupuncture. And there has been a couple of people who got very lightheaded, one person who fell. So we take our considerations very well in making sure that they gradually get off the table and gradually get up before they leave the treatment room. So this is what we really want to know. Do you have any porcupines here? Come on. So we really want to know, does acupuncture really work? And that's a very interesting question because it's been raised, and there's going to be 3 meetings going on this week about acupuncture in Boston. There's one called the Society of Acupuncture Research. There's one called the Fascia Society, which Dr. Langevin, who works here as well at the OSHA Center, is working on, and the Society of Integrative Oncology. So 3 societies are getting together to try to work on what is the mechanism of acupuncture. And on Tuesday next week, there's going to be a whole series on oncology acupuncture as a specialty, because it's probably in oncology where the most of the research work has been done with respect to acupuncture. But why research? Basically because use of research studies and technology to better understand acupuncture and integrative therapies. We recognize that patients are using a lot of these therapies, and we want to make sure that there are no potential interactions, and we've made sure that they're doing the right kind of research work. Well, what are the research issues? One of the questions I always asked about, how do you compare, what's the control group? How do you compare Reiki to a control group? What's the control for massage? No massage? So that's the whole aspect. What do you do as far as a control for acupuncture? What we've been doing recently is doing sham acupuncture, fake acupuncture. But it's very interesting. We're beginning to see acupuncture, not only sham acupuncture, but true acupuncture, giving somewhat similar results, but better than a weight control group. So we're beginning to reevaluate what should be the best control mechanisms for randomized clinical trials. Should it be the exact same thing? So that brings up the whole question of the 4th bullet right at the bottom. Whole systems research versus reductionist research. We in the United States have been doing reductionist research. And I have always been a proponent of reductionist research. That is, you study the gold standard for a disease, and then if you want to make some improvements with pilot studies, you go through a phase 1, phase 2, and then you do a phase 3 study with the new investigational agent or combination of agents to see if it's better, the same, or not as better with more side effects than the gold standard. That's the reductionist form of research. That doesn't work very well with integrative therapies. And so we're beginning to look at that and how do we best do research with the integrative therapies. And that gets to the whole systems research. Because when Dr. Benson first started his work, it wasn't just doing the relaxation response. It was doing the relaxation response with nutrition and with physical activity, going back to some of the clinics we saw in Tijuana, Mexico. So these are some of the research projects that we've done. We've studied immunological activity, physical status, and quality of life in connection with 2 exercise programs. Paul Richardson, one of our myeloma experts at the Dana-Farber. The acupuncture on pain, nausea, and quality of life in advanced cancer that I showed you one slide about. Acupuncture in neutropenia in ovarian cancer, a very interesting study. Maybe I'll get a chance to show you that. Qigong on mood and cortisol in breast cancer by Ursula Machalunas from our ovarian cancer group. Suzanne Bauer-Wu from the Berkeley School of Music, Suzanne Hanser is the coordinator from the Berkeley School of Music, a music therapist on the music therapy with metastatic breast cancer, and then the Reiki and relaxation response in prostate cancer patients receiving radiation therapy. So this is the R21 that I got in first days of the National Center for Complementary and Alternative Medicine. We studied 40 patients getting acupuncture over the 8 weeks. We found it was feasible to do, and we reported our positive benefits. This was the overall, as you can see, the confidence levels are not 100%. We did get some good response rates, but they weren't significant. The study was underpowered, and we're continuing to evaluate the effectiveness of acupuncture on pain, and there have been other studies done to show that it is evidence-based. This is the study that Wei-Dong Liu has done with Urchula maculonis in the ovarian cancer group. And this was a randomized clinical trial comparing active acupuncture with fake acupuncture or sham acupuncture. And people got we were testing the hypothesis that acupuncture administered during chemotherapy can produce a higher white count. I was very excited about this as a hematologist. What are we doing as far as using all these growth factors to boost up the white count? So we were testing whether or not we could get a higher white count and our ANC compared to sham acupuncture at the nadir of cycle 2 and the first day of cycle 3 of chemotherapy protocols. We were also looking at GCSF levels, and we thought about testing the feasibility of conducting this trial. So I don't know if you can see this, but we gave acupuncture 2 to 3 times a week, and we began this active acupuncture starting at day 15 after the first cycle. So here's the schema. First chemotherapy, first day of acupuncture on day 15 with the blue, and again the second nadir, and then measuring the white counts and absolute neutrophils counts at those days, comparing the active with the fake acupuncture. So acupuncture 10 sessions during day 15 through day 26. And so this was for newly diagnosed patients getting standard carboplatin and paclitaxel, and looking at the myelosupressive chemotherapy and looking at the regular acupuncture. The eligibility was no previous acupuncture in the past 120 days, and actually no acupuncture use at all, because if you knew you were getting sham acupuncture and had previous acupuncture, you knew you were getting sham acupuncture. So we had to take people who were naive to acupuncture. So we enrolled patients to get active acupuncture as sham, and the study results show you that I don't have a slide pointer to show you, but the first recovery, as you can see in the 10 patients, was 5,600 in the active acupuncture, and the sham was 4,400. And then at the second recovery, 8,600 compared to 4,400 as far as the total white count is concerned. And very similar with respect to the absolute neutrophil count. Here's the active white count. You can see the active versus the sham right next to each other. They asked not to statistically increase. You can see the p-value at the recovery is statistically significant at a 0.046 level, but not at the nadir level. And similarly with the absolute neutrophil count with active acupuncture. The study is a very low-powered study, so we're actually doing this again in a randomized clinical trial and trying to power it up a little higher, and also considering whether or not we need to have a sham arm or whether we can do this just with a weight-controlled group. So I'm not going to go through this, but here's another example of a study we're doing currently, a pilot randomized controlled study of comparing acupuncture with other therapies for induced chemotherapy-induced peripheral neuropathy. The background is that chemotherapy-induced peripheral neuropathy is one of the most common side effects of taxane chemotherapy. Paresthesias, pain of extremities, very common, as many of you who are treating patients have realized. The incidence ranges from anywhere from 30 to 97%, so really a significant complication. Loss of physical function, really, the patients really complain drastically about this difficulty in daily living, decreased quality of life, and has led to dose reductions, unfortunately. And so we're really risking therapeutic results by reducing the dosage. So there's no established therapy that's currently available, and we're trying all sorts of things. So we have, the history reveals in meta-analyses, 31 studies with over 4,000 patients. The incidence is about 68% of chemotherapy-induced peripheral neuropathies. That's 1 month, and 3 months later, it's still 60%. And greater than 6 months later, still 30% will still have peripheral neuropathy. So overall, this is a significant incidence of paclitaxel-induced neuropathies. So we have a small number of studies which have looked at this. Randomized clinical trial of 64 patients reported response rates of 88% for this, for paclitaxel-specific CIPN. But there hasn't been any studies to date specifically for breast cancer. And there's a study done for electroacupuncture for thalidomide bortezomib-induced peripheral neuropathy. And this also showed benefit studies and also was a feasible study. So there's lots going on that we can talk about later on, and I have some other slides to discuss later with the fellows. But here's a case report. This is a patient who joined the study from November 2014 to January 2015. The pain neuropathy scores at the beginning were 9 out of 10 in both hands and feet. Received 18 acupuncture sessions, and the pain scores at the end of the study were 3 out of 10 for the hands and 6 out of 10 for the feet. So the patient continued to get acupuncture post the study, and the pain scores fell further to 2 out of 10 and 4 out of 10 as of June 30th, 2015. And this is a quote by the patient: "I have tried everything and nothing works for my pain. After acupuncture, I can feel my toes and fingers. It is wonderful." So this is one significant thing that we really need to continue to look at. And there are other systematic reviews evaluating acupuncture. One randomized clinical trial from China with an 88% response. Another one from Schroeder et al. In acupuncture medicine with a 76% compared to a control of 15%. But a lot of these studies currently are poor design and not well controlled and underpowered. So that's why we're trying to do one in stage 1 to 3 breast cancer, where they will be getting the paclitaxel, and they already have a presence of grade 1 or greater neuropathy. So we'll see what the outcome measures are going to be: the patient neurotoxicity questionnaire, the functional assessment of cancer neurotoxicity, the EORTC quality of life questionable cancer symptomatology, and the chemotherapy-induced peripheral neuropathy from questionnaire from EORTC as well. And then blood draws as well as a patient log. So we try to aim to evaluate the impact of acupuncture on these scores and also the response rate as defined by the proportion of patients in whom there is 1 unit or greater reduction in the peripheral neuropathy scores. So we currently got funded by this by a Korean group of acupuncturists, interestingly enough, and we'll be continuing to evaluate this. So it's almost complete. We're more than 3/4 of the way through the study, and hopefully by next summer we'll have completed the study and completed the evaluation. So what about the financial issues with respect to funding research in integrative therapies? So as you know, we have 2 organizations: the National Center for Complementary and Alternative Medicine and the Office of Cancer. And this is the data so far. In 1998, you can see there was about $19.5 million in the NCCAM and 28 million in the Office of Cancer Complementary Alternative Medicine. It went up when we formed the two societies, the two centers, to 117 and 129, but it hasn't gone up further. So there currently is just about a little over $250 to $300 million provided by the government into integrative oncology research in integrative therapies. Not very much. Some of it goes to cancer, some of it goes to other chronic illnesses such as neurological diseases, etc. So we don't have a lot of money for research, but I think foundations and other groups and philanthropic groups have to fill the gap as far as that's concerned. I wanted to end by just talking about the integrative oncology of the future. In discussions with the people here at University of Vermont, I found out that what you have is tremendous resources in handling the cancer patients and also in handling other chronic illnesses throughout the campus. You have tremendous resources. You do have palliative care, you have pain therapy, you have social workers, you have nutritionists, you have physical activity people, you have physical therapists, and you have all sorts of criteria and treating. You have now practitioners, massage therapists, you have MindBody people. And the idea is trying to put all of that together into an integrated approach. We now know that cancer is now defined more by a genetic defect and less by its site of origin. We now need to individualize cancer risk, individualize cancer therapy, and we have to individualize integrative therapies. Why not? We're doing everything else by individualizing it. Why don't we individualize the integrative therapies? What is best for each individual cancer patient with respect to their disease? With respect to, should it be acupuncture, should it be massage, should it be mind-body program, should it be nutritional advice, should it be physical activity? So here's what you have. We have this at the Dana-Farber. We have pain and palliative care. We have ethicists. We have practitioners, nutritionists, spiritual advisors, physical therapists, specialty consultations. We have, in addition, psychosocial oncology. We have support groups, patient and family care services, nurse specialists, social workers. We have all of those that are available to the cancer patient. But how does the patient and the primary care oncologist or the primary care physician know what is best for the patient? Who makes the decision, the patient or the physician? In oncology, the physician is so overwhelmed with the chemotherapy protocol, with the eligibility criteria, for discussing the side effects, the outcomes, and what's next as far as the diagnostic and therapeutic procedures. They don't have time to delve into the integrative therapies or the available resources. So how do you do that? There is one suggestion that I've been trying to push for a while, and that is the use of a coach navigator. Someone who can sit down with the patient, the primary care oncologist or the primary care physician, learn about the chronic illness, know all the resources that are available in your facility, knowing on the basis of this individual patient's genetics, disease, background, ethics, religion, what might be best for that individual patient with respect to all the integrative therapies. There's a lot to choose from. Patients don't know which one would be best. In many cases, when I first started out, the patients did know more than anybody about integrative therapies. Now, with all of the research going on, I think we're getting it on an equal platform with patients. But I still think we need to be ahead of our patients by knowing what it is that we can recommend to them that might be beneficial based on evidence-based studies. So that's sort of just a suggestion about having a coach navigator. Often that turns out to be the one spending the most time with the patient, the nurse practitioner, the one who gives the therapy, or the radiation nurse practitioner who spends more time with the patient every day as they're coming in for their radiation therapy. So this is just a proposed model that I throw out there. So just ending, this is the Society of Integrative Oncology. the mission of the society, which has the meeting starting Monday, this weekend, to advance evidence-based, comprehensive, integrative health and to improve the lives of people affected by cancer. So this will be our 15th, our 12th meeting going on in Boston. This is a Society of Integrative Oncology, it's a 12th International Conference. Time flies when you're having fun, but this will be at the Boston Park Plaza Hotel this weekend. And then there's a joint conference going on Saturday, and this is with Dr. Langevin, who still comes here to Vermont. She and I sat down one day and said, you know, there's going to be a new meeting of the Society of Integrative Oncology. It's going to be here in Boston. How about the OSHA Center and the Society getting together and having a combined conference? She said, Helena said, well, you know, I've got 2 other organizations that also want to meet in Boston. Why don't we have a combined conference? So as a result, we have the Society for Acupuncture Research, the Society of Integrative Oncology, and her organization called the Fascia Society, which studies elasticity of the fascia. And that's her research work, and there are a number of people throughout the country who are coming to this meeting to discuss what is the mechanism of action. How does acupuncture actually work? Is it beneficial? So, we now know that it does work, but in this country, in China, they know it works and they know it's safe. In this country, we have to prove it's safe, prove it works, and show how it's effective. And that's the aim of this joint conference that's going to take place on Saturday. So this is the CIPN Bridge. I don't know how many of you have gone over it. This is Lenny CIPN, and it only takes one person to start a revolution of thought and spirit. And we owe a lot to Lenny CIPN. His wife carries on his mission. She's arranged for the lights on the CIPN Center to go on in different colors, depending upon the season and depending upon whether it's Breast Cancer Month or some other month of philanthropy. So again, it takes only one person to start a revolution of thought and spirit. So thank you very much for your attention.
Thank you for your talk. You were sort of implying, I guess, the difficulty of masking
Louder.
treatments with the acupuncture, for example. And I was just curious if you've either tried to control diet in the 2 groups or have examined whether diet is changing, such as fat composition, for example, see if there are extraneous linked factors that people respond to.
The question was, have we combined nutrition research with acupuncture research?
Well, even controlling for it.
Controlling for it. No, we haven't done that. Obviously, that's the systems research that we're talking about. No, what we've tried to do is do the reductionist form of research, and we're trying to advance it to becoming the more systems research. But essentially, that would be very difficult to control. It would take a lot of effort to make sure that our nutritionists, we do have nutritionists who try to meet with every patient prior to the chemotherapy, but to try to make sure that their diet stays stable during acupuncture therapy, I think would be very difficult to do. So no, we haven't done that. And I'm not sure there's any evidence that, the only one piece of evidence, there's a Chinese acupuncturist guru who says, I don't respond to acupuncture. I give it and all my patients respond, but I don't respond. And I'm a smoker. He smokes cigarettes. And apparently there is some chemical that comes out of the smoking into the bloodstream that affects the local area of the fascia of the subcutaneous tissue that may be interfering with the acupuncture stimulation. That's all I can tell you about right now, but we hopefully will learn more on tomorrow.
Dr. Rosenthal, thank you very much for this interesting talk. I think many of us are wondering, why does this work, or does it really work? Has anyone proposed an inexpensive control group by taking all the variables that seem to be involved here, which are human involvement, sensory stimulation, and a quiet environment. So if you take a person and put them in a quiet, soft room with an individual who touches their body in some way, it would seem to be very inexpensive and perhaps might obtain almost the same or close to the same results in a relatively quick time, and many people would be willing to be a control member of that group.
Right. Well, good question, and I think that the whole question is, how do you control for the placebo effect? It's the first time I've mentioned today, this morning, the placebo effect. But a lot of people obviously criticize a lot of the evidence-based medicine in mind-body medicine, in Reiki, in acupuncture, as being, quotes, the placebo effect. And looking for ways to control for the placebo effect is what you're talking about, in trying to control for the environment. And I think it's a good question.
Which
Yeah.
is a very important part of our body.
Exactly.
Yeah.
And my massage therapists have great slides to show the actual touching experience and what that does to the body and how it stimulates various subcutaneous tissues.
Hi, thank you very much for that very nice presentation. I saw on the acupuncture study that you presented, the error bars were quite large, and you touched on it at the end that there's a very large variation in response due to individuality. Do you have any thoughts or ideas, anecdotal evidence as to what may be most successful, or if you can tell if the patient's going to respond?
Well, I think one of the complications things is the dose. I mentioned dose. So we have some pilot studies to show that giving acupuncture 3 times a week rather than twice a week can actually do more for the peripheral neuropathy and the blood counts. But we haven't done the randomized clinical trial yet. But we're finding that dose does play a significant role. And the more acupuncture you can give, the better off you may be with the results of the study. So I think that's one component that we're looking at.
Thank you very much. I am asking a question about the cardiomyopathy. I'm a mom of a leukemia survivor, and I'm just wondering if you work with childhood leukemia people or adult leukemia patients, and what was the cumulative dosage that the people who needed the heart transplant?
This goes back.
Yeah.
Okay. The question is about cardiomyopathy and chemotherapy, and I hinted at the fact that this was going back to the 1970s, 1980s, when we first were beginning to get good remissions with an anthracycline, but it was high doses of anthracyclines. So that was the major reason for the cardiomyopathies. Currently, we're well under the dosage that's causing cardiomyopathies now in children and adults. So it basically was a dose-related phenomenon. We're not seeing it now, but in those days, we didn't know how much adriamycin or anthracyclines we could give.
So we're running out of time, but there's questions and answers and breakfast and coffee and everything out there. And Dr. Rosenthal will be around to answer questions, correct?
Right.